Good afternoon, everyone. Am I audible?
Yes, you are.
Okay. So today we are here again for the session of revision of BCBR. So first of all, I would like to introduce myself. Myself, Dr. Divyata Detha, first year resident, Department of Physiology in Government Medical College, Bhavnagar. So for the first lecture, I would like to welcome Dr. Kalpita Ma'am, Assistant Professor, DSM Department, GMC Baroda, for guiding us on the topic of validity of epidemiological studies.
I'll just share my presentation.
Sure, ma'am.
Can you tell me if it's visible?
Yes, ma'am.
Okay. Thank you.
Yes, ma'am, visible.
Okay, thank you. Fine. So for the next 15 or 20 minutes, I shall be talking on the validity of epidemiological studies. A very good afternoon to all of you. So what is the need, or why do we look at the validity of epidemiological studies? So the basic idea behind this is that usually because of lack of time or manpower or money, I'm not able to take a complete survey of the entire population or include the entire population in my study. What I do is I take a representative sample, I do my study, I get my findings. Now, if those findings are restricted or they are true to the real sample which I have taken, that is known as the internal validity. If I have an internal validity, only then I can conclude that the findings of my sample may be generalizable to the entire population. So conclusions based on the sample will be there only if the sample internal validity is present. So this generalizability is known as the external validity. So what is this internal external validity and how is it affected, or how is it going to take a claim on my main findings or my inferences? That is the topic for today. So the basic objectives of epidemiological studies, as in the previous slide, shows that I need to have an accurate estimate of whatever disease frequency or whatever findings I get from the sample should be true to that sample. If there is any effect of some exposure on the outcome, especially when we are talking about health outcomes in the study population, they should be true to that particular sample, and this is meant by internal validity. Once I get the findings of this sample or maybe multiple samples, and I want to know whether it is going to be generalizable to the target population from where that sample has been taken, that is termed as the external validity. Now, this example, external validity or internal validity plus precision, both these things together are known as accuracy of a study design or accuracy of the study findings. Let me tell you what is precision. If I repeat anything twice, thrice, 4 times, I should get a similar result, and that is known as precision. But if it is very near to the real truth or the real value which is there in the sample or the population, that is known as validity. So if I take a look at this slide, you have a bull's eye, that is the central point. So the first figure shows that the values are precise as well as valid. So if the bullseye is the real truth or the correct truth, all the findings repeatedly are coming near that truth. So because repeatedly they are coming at the same place, and they are also near to that bull's eye or the center, it means that these findings are precise and valid. But when you look at the second red circle, all the findings are repeatable. So the precision is good, but they are very far from the truth, that is the center. So there is no validity. In the next circle, it shows that it is valid. It is very much near the central value or the true value, but it is not repeatable. They are going in all directions. So these findings can be called valid, but they are not precise or they are not repeatable. And the last one shows no precision nor validity. So just giving an example of how do we define internal external validity, or what are the reasons why you can get some false results. Take a look at this slide. It mentions that coffee drinking doubles the risk of heart attack. So I have an exposure, which is coffee drinking. I have an outcome, which is 2 times the chance or risk of heart attack. So when I just read this, this is known as the crude association. Crude association could be true, it could be false. If it is true, it means I have good internal validity as well as I can generalize it to the population. When can I be wrong, or when can I get some error in estimation, meaning that this association between coffee drinking and heart attack is not true, or it is not causal. That means coffee does not lead to heart attack, or does it really need to heart attack. So there are 2 types of errors. One is the random error, second is the systematic error. Random error is by chance. It is usually due to sampling error, due to errors in measurements. Mostly they are information biases. And there are certain systematic errors which are known as bias. Systematic would mean time and again they are bound to occur when I am doing a particular kind of a study with a particular kind of formatting. So bias could be a process that tends to produce results that depart or are away systematically from the true values. So when do these errors occur, and when do I get an error in the estimation of my true results or causal association? These are the 3 errors, and they are the actual threats to validity in epidemiological studies. So it could be selection bias, information bias, or confounding. Selection bias is when I'm trying to select a population depending upon my study design in an abnormal or a wrong manner. Information bias is when I'm collecting the data or information with some error. And confounding is an altogether third variable which shows association where actually the association is not present. So we'll be talking about all these 3 different biases which are threats to validity. So the first one is selection bias. So the question comes, do the study participants actually represent the target population? So this is where we talked about the external validity. And this bias results from procedures wherein I am not actually properly selecting the individuals to be included in my study, or the second part, that is the analysis of the study. And wherein can this selection bias occur? In epidemiological studies, it could be in surveillance cases where there is notification of only the exposed cases and no controls or no other comparison group is present. It could be in screening or diagnostic studies where I'm just looking at active case searching among only those who are exposed. Usually we tend to do studies in the healthcare facilities. So there will be cases wherein the patients may be exposed or not exposed to a particular exposure or a risk factor, and controls could be subjects who could be exposed, unexposed, but I am taking such patients who could be more exposed or not exposed, leading to over or underestimation of these associations. We may be including only those cases which are surviving or which are able to come to that healthcare facility or which are able to come to me in the community to give the interviews. So that is selective survival, which again would give us either less exposed or more exposed in numbers who would be interviewed. There could be non-response, or maybe I have taken a group of 100 people as a cohort and then later on they would drop off, or that is known as not responding, or maybe they are lost to follow-up. So those who are lost to follow-up or dropped off may be less or more exposed to risk or exposure. Again, that will give me a wrong count or a wrong association estimate. So how do I deal with selection bias? First, it could be in the designing stage of the study. I do not take only prevalent cases. I take cases, incident cases as and when they occur. Usually not taking a hospital-based study design, but using a population-based design so that there is no chance of only those patients or people coming to the healthcare sector who are included in my study. I should have strong proper similar eligibility criteria for selecting cases and controls, those with exposure, those without, those with the outcome and those without the outcome. And they should undergo the same, maybe the interviews, the diagnostic procedures, and the disease surveillance intensity in the same manner in the cases as well as the controls. If I need to look at the data collection stage of the study, usually that happens in cohort studies where I would try to minimize the non-response. Maybe I take a lot of follow-up, take a lot of care during the follow-up, try to follow them up telephonically, or maybe if once they are not available, I can go back a second time, a third time, etc. Also keep a record of how many people were lost to follow-up. Also collect their baseline data. Later on, it can be used in the analysis stage. And we also make sure the diagnosis of the disease is not affected by exposure. So this is done through blinding, which will be taken up in further sessions. I can also deal with selection bias in the analysis stage of the study, where I can compare whether they are non-responders, dropouts with those responders or non-dropouts who are there at the baseline. So that is one way of analysis. The other is what if analysis or sensitivity analysis. What if this person continues with the study and has an outcome? Or the second way of analyzing is what if they had continued with the study, but they did not get that particular outcome. So you often see sensitivity analysis being done when there is a huge amount of loss to follow. So the second threat to validity in epidemiological studies is information bias. It's the way I glean the information or collect the information or data through certain procedures or questionnaires. So the bias results from procedures used to measure the exposure outcome and other variables. I would be biased in thinking that this is a case, so the exposure may be more, would have been more, that's why they are a case. Or I would ask more questions on the outcome if I know that this person has exposure during a cohort study recruitment. Other than that, cases in a case control study would recall their exposure much more better manner rather than the controls. Again, this is known as a recall bias. I could be looking at better outcome data available on the exposed. I know these are the exposed group and I keep on asking them about the outcome data, but I don't care about those who are not exposed. Again, this is a kind of information bias. It could be an investigator bias, which is wherein there is systematic collection of information supporting expected conclusions. I have a mentality that, okay, this exposure leads to that particular outcome. I may be unconsciously asking questions pertaining to that particular exposure or outcome. So again, this can be examined in the analysis stage also. Certain subjects may be distorting the information, and this is known as prevarication. Again, it can be an MCQ that can be asked. So these are the different stages wherein we deal with the information bias. I should have a very clear definition of what variables I am looking at. How will I measure those variables? If there are any key variables or outcomes, say lung cancer, I need to have repeated measurements probably, or training and certification of those who are going to do that measurement or procedure. I would need to have proper data audits of the interviewers, of the data centers, how the data entry is done, how the data analysis and cleaning is done based on visual or computer applications, and also rerunning all the analysis before I actually go to the publication stage. So coming back to this, coffee drinking doubles the risk of heart attack. We already talked about the internal or the external validity based on subjective or information bias, selection or information bias. The second part we talked about was confounder. What is this confounder? It is a confusion of effects. So when I talk about this coffee drinking and heart attack, I would like to think, is coffee drinking actually related to heart attack, or is there any other issue or other exposure or other variable which may be leading to this heart attack? So the apparent effect of exposure of interest is distorted because there is some other third factor or extraneous factor which may be leading to this exposure. Confounder is something which will lead to overestimation or underestimation of effect, and it can even change the apparent direction of the effect. How? Let us see this. So there is an exposure, there is an outcome which I am looking at in a particular study. There is a third variable which may be linked to the exposure, linked to the outcome, but it is not in the causal frame. So it is not exactly the exposure leading to outcome. So these are the three conditions that are met in a for that variable to be a confounder. And this again can be an MCQ that is asked. So if there is no association in my study, if there is an exposure, and if I say that coffee drinking does not lead to cancer, fine. But if I say coffee drinking leads to cancer or leads to heart attack, I will need to show that whether it is causal, whether it is actually causing the heart attack. So this is another example in the same context. A study finds that people who carry matchboxes are likely to get lung cancer. So the first question is this association between carrying matches and lung cancer causal? So does actually carrying matches lead to lung cancer? Or is carrying matches or is there some other confounder which may be leading to this finding? So the first picture is those carrying matches, that is the exposure, leads to lung cancer, which is the outcome. The second part is those who are carrying matches may be prone to smoking cigarettes, and it is actually the cigarette smoking which is leading to lung cancer. So in this case, smoking is the confounder. When I need to analyze this, I do a stratified analysis wherein I'll have two groups. One is smokers, the other is non-smokers, and then I look at the association. Again, these estimates would be discussed in few further sessions. So carrying matches does not cause lung cancer. It is actually smoking which causes lung cancer. And that is the confounder in this context. So how do I deal with confounding? In the design stage, I can have a particular stratum of people whom I am interviewing. So it could be either those with matchboxes or those without matchboxes, those with smoking or those without smoking, depending upon what is my exposure and outcome of interest. I could be matching people, those who are, I could just match age or gender, so which I think are the confounders, so that it will reduce the chance of confounding. Again, over matching is also not very advisable. I can do randomization as in experimental studies, so that at the stage of randomization, the confounding variables or all the variables are equally distributed in both the groups. At the analysis stage, as mentioned, we do a stratified analysis or a multivariate analysis to look at the confounders. So basically, when I look at, when I told that coffee drinking leads to heart attack, that was a crude association. I look at whether there is any chance association. If not, I look at whether there are any selection biases or information biases. If not, I look at whether there were any confounding factors associated here. If I get a no for all this, only then it means that this crude association is the actual causal association. How do we do it in the given example? Does coffee increase the risk of heart attack? So this is the truth in the universe that all adults, I have selected all adults, not all adults, but only those who consented for the study. So maybe the participation rate was less. Maybe they were hospital patients who already had a risk of heart attack or gastric ulcers, etc. Maybe because which led to gastritis and so false reporting. There could be some people whom I have taken in the study who are strong coffee drinkers, but the rest of them who are not in the study were not coffee drinkers. I'm also, this accounts for the selection bias. I'm asking about the actual coffee intake and the actual heart attack. There could be a reported coffee intake which could be lesser or more as the true intake, or there could be misreporting or misdiagnosing of the MI or heart attack. So this amounts for the information bias. So was the confounding association between coffee and MI due to confounding by smoking? Let's take a look. So most of the times it could be that those who are smokers also drink coffee, and it is because of that they have got MI. So the reason is smoking and not coffee drinking, as shown in this figure. So with this, we say that selection bias, information bias, confounding, they are a major threat to the validity of any kind of study. Confounding is the most serious threat to validity. Biases can occur in all epidemiological studies. It could be selection bias, information bias, confounding. It can occur in study design, implementation, and analytical stage of the study. And of course, they are going to threaten the internal external validity. So basically, through a strong study design, through a lot of planning and protocols, we can prevent biases. But some biases may be bound to occur, which can be which we cannot avoid, but which we need to understand and express during our discussion stage. So this can be put up in discussion or under our limitations. So these are a few of the MCQs which are often asked related to internal validity, external validity, bias, and confounding. We'll be sharing the presentation, so it could be open to all. Yeah. Thank you so much.
Thank you, Dr. Kalpitra,
Thank you, sir.
for taking question answer also along with the PPT. So it will be useful to everyone.
Thank you, sir. So you can share it if anybody needs it.
Sure.
Thank you, sir.
So thank you, everyone. Any questions? One or two questions we can entertain in the chat box because we have a limited time. And this is a quick revision. Madam, you can stop sharing the screen.
Okay, sir.
Okay. So the next topic is a qualitative research. So that will be taken by me. I know I'm not the expert of qualitative research, but I think I will be able to brief you, or I can say I can give you few things which will be helpful to you for BCBR exam. Okay. So can anybody share in the chat box what is the difference between qualitative research and quantitative research? Or have anybody heard about EPIC or AMIC? Anyone? Okay. So let me start with the difference. So right now there are broadly we can divide into three types of research. One is quantitative research, second is qualitative research, and when you combine both, it is known as mixed method research. Okay. So let's see the difference. Basically, what is the difference between quantitative and qualitative research? Now, in exam, they will give you a few of the options, and then you may have to identify is it a qualitative or quantitative research. So what is a quantitative research? We are dealing with the number. As the word says quantity. So quantitative means a numbers, 5, 6, 7 percentage number, all that things. And while in qualitative, it is a text. Okay. So because what we are doing in the qualitative, usually the qualitative interview, the whatever methods are used, we are recording the participants' views and then we are transcribing and then we are going further for the result. So it is known as a text. The view of the world. Now, quantitative is objective. It is a measurable, external to the individual. And so, in another word, it is known as a ethic from the external view. While qualitative is a subjectively interpreted and experience, and it is from within. When we want to know within, it is known as a amic. So, quantitative is external view and qualitative is inner view. Then, if we look at a logic of inquiry, here the logic of inquiry is deductive, testing a formal hypothesis. While here, it is an inductive, understanding of a social process there from the data. Okay. Here, research doesn't ensure the repeatability. I can repeat if you send me a questionnaire, the study of perception regarding the benefit of this session for BCBR review. So that I can ensure the repeatability. I can perform for other training also. While here, interpretation of response are subjected to research design. Okay. So this is the difference. Then as we have said, that validity is objective, it is a reliable, while here it is a subjective and so it is a credible. And lastly, cross-cultural generalization. Because if you want to generalize it for different cultures, the quantitative application of the same observation method can be used for the different culture. But here, require conversation in abstract intercultural category. So this is the difference between quantitative and qualitative research. Okay. Now, when to use a qualitative research? Okay, when to use this research? Let me try to enlarge it if I can. Yes, good. Yeah. So when to use a qualitative research method? There are a number of options. Number one is a view social phenomena holistically. Then suitable vocabulary is not available to communicate with the respondent. Then subject matter is unfamiliar or insufficiently researched. Then need to explore and explain the behavior. The next is a provide insight into a meaning of decision and action. If I take some decision or if I take any actions, you want to provide a insight. Then seek in-depth understanding. I said that, okay, I like this coffee very much. But what is like means what? So if I want to understand deeply that why you like a coffee so much, because it is prepared by somebody whom I like, or the taste is good, or aroma is good, what is good? Okay, so if I want to seek depth of understanding, then also I need to go for qualitative research. Then when we want to ask why, how, and under what circumstances event happened, it is also known as a qualitative research. So these are the few of the options where we are going to prefer qualitative research or go for qualitative research. Okay. Next, what are the methods, different methods? So right now there are a lot many methods, and we can have a 4 days, 5 days, or 1 week workshop on qualitative research methodology. But for BCBR, they have focused only for 3 methods. One is in-depth or individual interview. Second is focus group discussion, and third is participant observation. So basically, what is happening in this all the methods? There is a partnership between participant and investigator. Here, the investigator or instrument become a part of a process. Okay, even learner and co-interpreter also a part of a process. Here, it is emergent rather than pre-structured. Because if I ask somebody that why do you like the coffee, then what he respond, how they respond, based on that, we are going more and more deeper. Okay, then iterative rather than fixed, and it is interpretative rather than open-ended. Okay, or we can say combinedly both interpretative and open-ended. Is not a close-ended because we are open to discussion. So these are the mainly 3 methods: in-depth interview, focus group discussion, and participants observation. Now, what is in-depth interview? So if I ask somebody specifically that what is the regarding these sessions, what we are taking as a revision, if I do one-to-one interview and try to get more and more detail, then it is an in-depth interview. But for any qualitative interview, either in-depth or focus group discussion, we need to have an interview guide, which is a validated and structured interview guide is required. Once you approved or validated the interview guide, then you can start the interview. So when we want to go for in-depth interview, we have to use open-ended interview. And what is the use? It is to discover the interview's own framework of meaning. It is to obtain rich, contextualize and in-depth information, and to avoid imposing the research structure and assumption. मुझे क्या लगता है उससे कुछ लेना देना नहीं है, आपको क्या लगता है उससे लेना देना है. And how we will go ahead? Follow interview guide, as I said. Then sometime we ask probing question. Like as I said, you said I like coffee. Then I will ask why you like the coffee. Do you like the place? Do you like the person? Do you like the utensil? Or you like aroma? So probing question. Then the interviewer will reflect on the remarks made by the informant. Then everything is collected in respondent's perspective and their own words. Okay, and up to what level you have to go, that is varies with the type of interview. Now, when we can use a complex subject matter and knowledgeable respondents are there, then you can go for in-depth interview, because the person to whom you are doing interviewing, he is very knowledgeable and the subject matter is complex. Then highly sensitive subject which can't be discussed in a group. Okay, if you are discussing the reasons of divorce, then you can't discuss in the group, so you have to go for in-depth interview. This is on the lighter note. Then geographically dispersed respondent, they can't come on one place, so in that case you can do. but sometimes now people are using FGD online also, but it has its own positive and negative implications. Then peer pressure on issue, and there is a social desirability or a threat to open discussion. So in all this case, we will go for in-depth interview. Okay. So what are the advantage? It is the most in-depth, and we are going to discuss why a behavior is practiced. Then it gives a data on how people think and talk, and we are able to conceptualize the behavior. While when we are writing the exact word and language of people which is used for themselves, that we are going to put. Okay. And it is a amic perspective, as we have said beginning, it is an insider perspective. What is the disadvantage? Based on the few people, usually it is a not systematic sample, but purposeful or convenient sampling. It is not generalizable. Interviews are very long, lots of data, time consuming to analyze, and sometimes it is very difficult to transcribe also. And researcher opinion is here given more important, that what the data means. Now, when we are using his word, the sample size, so in qualitative, the difference between quantitative and qualitative is, in qualitative, we are going to have a sample size till the saturation is done. Now, what is the saturation? That if I am asking a question to 10 people, and now from 11 and 12, I am getting same response. So it is means saturation. So usually it is said that after saturation, you feel that it is saturated. Again, you try to do interview for 2 people, and then you can finish if you are getting the same thing. If you find something new, again, you have to go till the saturation, and then you will be able to complete your sample size. Okay. Now, second is a focus group discussion. So as the name itself stated, it is done in the group. Similarly, you have to have an interview guide which is validated, structured, and this is an open-ended group interview that promote discussion between the participants on specific topic. So sometimes the people are also developing a discussion map at the end of focus group discussion. के यहाँ गया, फिर इसने बोला, फिर इसने बोला, फिर इसने बोला. Like that, you can have a map also. So usually done with the 6 to 8 similar participants. Similar means similar in age, gender, socioeconomic status, education, and others. Okay, and they have a similar cognitive structure, similar perception of their social environment, and similar normative beliefs. Okay, so what you require? You require a moderator and note taker, and based on the discussion, you can go here and there in interview guide. Now, in both the cases, if you don't have a note taker, you can record the interview and then you can transcribe. But here again, you have to take 2 consent. Number 1 consent is to record the interview. If they say no, then they can't be your participant. And secondly, consent for participation. Okay, so these 2 are required. Now, when to use? The group interaction is important. At that time, you can use it. A cost and timing issue. If I have to go here and there multiple times, rather than I can ask everybody to come at one place and I can do the interview. You want to do an idea generation. At that time also you can go for focus discussion. Then from problem identification and define the goal. Identify the local or group specific vocabulary or terminology. I may be using one word for one thing, one problem, and in another area, for example, Maharashtra, they are using a separate word. Karnataka, they are using a separate word. And evaluating message for an intervention. So if you have done some intervention, recently we done one intervention of a large group meditation, and then we did the focus group discussion, because you want to evaluate the messages from an intervention. Okay. What are the advantage? Some people are more comfortable and talk more openly in the group, because I am not only there, multiple people are there. Natural way of some people to talk about problems and personal issue in some culture. It collects information on social norms and can provide lots of data in a limited amount of time, because I have given only 1 hour and have a group of people, so I can get lot many ideas or data in 1 hour. What is the disadvantage? It is difficult to access practice of a very personal or sensitive behavior, because whatever personally I am doing or sensitive thing I am doing in person, I am not going to discuss in a group. It is not generalizable, because sometimes it happens in group. Some people are dominant and some are not dominant, and some are, we can say, dormant. So dominant people may overcome the discussion. So it may be sometimes biased. Now here the transcription type is consuming, and often it's 30 to 40 pages. And really what we did recently, we have around 45 pages. So we have a transcription of around 45 pages, and difficulty to identify the speakers. But now softwares are available, recorders are available, you can use, and even AI can also help. We have also took the help of AI. The third method is participant observation. Now, what is participant observation? The researcher become participant in a social event or a group, understudy and records the observation. I can just go there and sit and observe what is happening. Okay, I will become a part of an event. For example, I want to record what is happening in a camp. So I will become a part of a camp and then I will observe. Data is very deep and detailed because I am then and there and I myself is observing what participants are doing. The disadvantage is difficulty to systematically collect, especially in the middle of important moment. Okay, because sometimes not you are not in a position to note each and everything, and once you go back and you start doing noting, you may have forgotten something. Okay, and if you go into the analysis part, the analytic method for observation notes are not well described as it is there in a FGD and in-depth interview. Okay, so now how you will do the analysis of text available? So there are here again lot of theory, but two important theory are grounded theory and content theory. Now what grounded theory says, you are going to do transcription of the interview, then you can develop a categories, and based on then we will do the themes. Now from where category will come? From coding category will come, and from category it will go to the theme. Okay, so there is a relation between different category, and ultimately it is based on the theoretical model. Okay, for example, what you can put a course from the interview in a grounded theory, while in case of content analysis it is based on a theoretical framework. It is a set of codes for a variable in the theory, and these codes we are going to apply systematically. Okay, and the further unit of analysis is by variable matrix from text and code. So what is the difference here? There are category code, category and theme. Here you have mostly have a codes and text, and we have to systematically or statistically analyze the matrix which is developed at the end of transcription. Okay, now what are the different ways how can you use this? So number one method is you have a qualitative data available. Based on that, you form a survey form. Based on the qualitative interview, you will develop a survey form. For example, your attitude and practice in a biomedical waste disposal. So once you do the qualitative analysis, you will come with the code and themes. Based on that, you will prepare a survey form, do the quantitative analysis, and then go for a result. In some places, you can combine both quantitative and qualitative, and ultimately you get the result. And in third cases, so here there is a mixture, or we can say triangulation of quantitative and qualitative. And last method is you can have both the separate and you can go for a result. Okay, so this will be a primary data collection method. This is a secondary data collection method, and you can go for a result. When you are going for a qualitative research, there is an important part which is a triangulation. Okay, so there will be a triangulation of data source, method, and theory. Now, why it is required? Because when you do the triangulation of theory, it controls for a selective perception and interpretation bias. When you do the triangulation of data source, it helps us to understand the difference. Okay, and not to achieve a convergence. And method will help you to focus on what is learned by the degree of convergence. And that's why we need to go for a triangulation of these three. Okay, now how they are useful? So they are useful because they identify the head determinants. For example, underlying behavior, attitude, perception. They also shed light on the success of intervention. It is a success or not success. It also facilitates the understanding of policy, social and legal context in which decisions are made. And lastly, it explains the social and programmatic implementation to inform choice and use of services. For example, JSSK. For example, NHM, like that. Okay. So this is the way. So lastly, how the qualitative data is useful or qualitative intervention is useful. it helps to triangulate or to check the hypothesis. It used for a comparative advantage of combining both, and it is to explore and ask why of what is happening and to seek an in-depth understanding of what a problem is. Okay, so this is a nutshell regarding qualitative. And as I said, that if you combine qualitative and quantitative, this is only in the simple term. It is not like simple if 1 plus 1 is equal to 2. But when both methods are there, it is known as a mixed method approach. Okay, thank you very much. Any questions? Okay. Grounded theory means that, for example, I have done collected the data, then I have done the transcription. Now, when I will go in the transcription, there are certain words which are coming again and again. So initially it is known as a coding. So based on the category, you combine this code and make the category. For example, we will use the same example of coffee. That based on the coffee, if I said that I like it because of place. Now in place also I have a multiple code. That chairs was good, then table was good, like that. So it will come sitting. So codes are table, stool, and all that. Category will be accommodation. So from category, ultimately you go for the theme, that it is based on the more of a facilitation or more of a feeling of an external environment that will become the theme. So when you are doing like this, it is known as a grounded theory. Okay. And Dr. Parag has nicely mentioned in one word, theory which is grounded in the data. Thank you very much, Dr. Parag. And any other question to anybody? Okay, thank you. Over to next speaker.
Thank you very much, sir, for sharing your valuable insights. Now I would like to welcome Dr. Hitesh Chauhan, sir, Assistant Professor, Anatomy Department, Government Medical College, Bhavnagar, for shedding some light on the topic of measurement of study variable. Please welcome, sir.
क्या नाम है मंजू? क्या कर रही थी? क्यों?
Good afternoon, all. Let's see the today's topic, the study variable and its measurements.
किसको दिखा रहे हो?
What is variable?
क्यों?
Variable is the measurable characteristics.
हाँ,
It can be vary from person to person, or it can be vary within the same person over a time. For example, you can take a blood pressure.
डॉक्टर को दिखा
It
के
will be
आओ।
vary from person to person.
डॉक्टर को दिखा के आओ।
And similarly, it can be vary over a person over a time. For example, it will taken here and it will be taken in the morning hours. It will be changed. So it's a variable which can be vary from person to person or within the same person over a time. Now, this type of variable are of two variety, the qualitative data and the quantitative data. That qualitative data that can be of two variety, nominal variable or ordinal variable. The nominal variable is just a name which do not have any specific orders like a blood group or a sex or a ethnicity. So they can be measured or summarized by a proportion or a mole. While ordinal variable which have some logical orders like a stages of the disease, like a chronic renal failure or a stages of any other disease or a severity of any disease. So this can be summarized or calculated by a median or a mode. Now, quantitative data that can be of two variety, discrete variable or continuous variable. The discrete variable means that will be having a whole number, like a number of children. That cannot be half, it should be a full number. So they are discrete variable. While continuous variable is the any value which will be including the decimals. So that continuous variable that will again divided into two variable, interval variable and ratio variable. So interval variable is the one where we can divide the whole data into intervals, like a 60-degree temperature, which will be, if you go up 30 degree and down 30 degree, that will be interval that will become similar. But if you observe the temperature, is the 0 degree centigrade means no temperature? Is it so? No. There is some temperature, and even we have a -degree temperature also. So in interval variable, there is no any reasonable zero. While in a ratio variable, we have a reasonable zero. And that is why here we can say that, like in age or a height, we can say that 40 kg is a double of the 20 kg. Or we can say it's a half of the 80 kg. So they are the example of ratio variables. Now, these variables can be measured either by a central value or by the dispersants. And the measurements of the central value can be done by mean, median, or a mode, while measurements of the dispersion by the range, mean absolute deviation, interquartile range, standard deviation, or variance. So let us see each measurements one by one. So central value that can be measured either by a mean, median, or a mode. So the first one, that is an arithmetic mean, that is most commonly used method. And the sample mean is denoted by x bar and population mean is denoted by mu. So how we calculate the arithmetic mean? So first we have to add all the observations. So we have to make a sum of all the observations. And then we have to divide that all the observation sum by a number of observations. So that is a formula for mean. Let us see it by the example. The age of 10 pregnant women who has visited the ANC clinic. And these are the data we have. So what we can do is we have to calculate the sum of all the observation of age of all the pregnant women. So that is 260. And we have 10 number of pregnant women. So N is 10. So we can calculate the mean, that is 26 years. So the mean age of pregnant woman who visited the ANC clinic is 26 years. Again, let us see why one more example. Here we are seeing the test score of the students. And we have taken a sum of all the observations divided by the number of observation. Now just see that all the students which will be having a nearby marks. But some student, if one student is having a highest marks, and it is much more than the other student, and you can observe the mean, it is much more change. And that is why we can say that in an extreme value, arithmetic mean is not useful. Either that extreme value can be a very big also, or it may be a very small also. So what we can do for that extreme value, we can do a median calculation. So what is median is, it's a middle value of the distribution, so that it will divide the distribution exactly into the two halves. 50% on the above side and 50% on the below sides. So let us see how we can calculate the median. We have to arrange first the data into the ascending order. Remember, in BCBR questions, there may be asked to calculate the median, and they are not arranging all the observations in an ascending order. So you do not have to forget, we have to arrange the data in ascending order and then calculate the median. So now if the number of observation is odd, we have to calculate the median value by n plus 1 by 2. And that number of value or observation is your median value. But if number of observation is even, we have to take an average of the middle two values. Let us see it by the example. There is a duration of hospital stay of 11 patients is given, and we have arranged the data in an ascending order. So we have total 11 number of patients. So n is odd. So we have add 1 within the 11. So it's a 12, and 12 by 2, it's a 6. So it's a sixth value. So it's a 1, 2, 3, 4, 5th, and 6th value is the median of the given data. But if you compare the mean, it is differ, because there is a presence of extreme value 77 is present. Similarly, if the number of observation is even. So here we can say there is 8 number of observation. So we have to take an average of middle two value. And this is, again, you can see that it is not affected by the extreme value. And that is why the median is useful when there is a presence of extreme value. Either it is bigger or a small. Another measurements is mode. What is mode? It is a value which occurs the most frequently in the given data. And this is the only statistics can be used for nominal data or non-measurable characteristics. So if we are given a data, the mode may exist in a data. Sometimes the mode may be absent in the data, or sometimes there may be a multiple modes within the single data set. So single data, the mode can be exist, mode can be absent also, or sometimes maybe multiple modes also seen in the given data set. So let us see with the example, we have a color preference of people for their car. And if we see it, there is a more people we have choose a yellow color. And that is why the mode is yellow. Now we have seen the central value. So that is we are calculating the average. But is calculating the average is sufficient? Let us see. Your height is 5 feet and the average swimming pool depth is 4 feet 5 inch. And you do not know the swimming. And if you go into the swimming pool, you do not drown. You have to know the dispersion. Why? Because if we say the minimum depth of swimming pool is 3 feet, but the maximum depth is 9 or 10 feet. And if you are going into the swimming pool area where we are having a depth of 10 feet, you'll surely drown. So that's why we have to know the spread or shape of the data within the group. And that is the measurements of dispersion. And that can be measured by either range, interquartile range, mean deviation from mean, or a variance or standard deviation. So first let us see what is range. So range is the difference between the minimum and maximum value of the observation. So it is easy, quick method for dispersion, but if the minimum and maximum value are far more extreme than the most of the data of your given data sets, then it can be influenced by the extreme values. And here we are using only two data points, the first or minimum data point and the maximum or a last data points only. Another is interquartile range. And here we have to take a range and divide whole range of data into 4 quartiles. So we have a first quartile, that is a 25th percentile. The second quartile, that is a 15th percentile. And do not forget, it is our median. So sometimes BCBR may twist that and put a median instead of second quartile, or vice versa within the data set or your MCQ. So do not have to forget that it is 15th percentile is a median only. And the third quartile, that is 75th percentile. So what is interquartile range is the interval between the value of upper quartile and lower quartile. So we can say that interquartile range is Q3 minus Q1. And this is not affected by an extreme value, which is either present on the smaller side or a bigger side. But the disadvantage is it is only covers the middle 50% of the observations only. It's lower 25th and about 25% is excluded in that interquartile range. And that is why it sets disadvantages there. So let us see the example of interquartile range. The body weight of 11 children who attended the pediatric OPD was measured. And for this group, the first quartile, median, mean, and third quartile were respectively is given. So we can note it down that the first quartile is 8.5, median is 12, mean is 11.9, and third quartile is 16. And what we have to do is we have to calculate interquartile range. So it is Q3 minus Q1. So it's a 16 minus 8.5, so it is 7.5. Another is mean deviation from mean, also known as a mean absolute deviation. Although it's not making a mate, it's a mean deviation from mean. So it is an average of absolute deviation of the observation from the arithmetic mean. And we do not have to forget, we have to ignore the sign. Let us see with the example. Here we have given a data set. Now, first, what we have to do is we have to calculate the mean. And now subtract the mean from the each observation. And now we have to ignore the sign. So we have to make the plus of the minus observation. And then we have to calculate the mean of all data of deviation. So here we are ignoring the sign. This is very much important. If you forget the ignoring the sign, mean deviation from the mean is always you get 0. That is why we have to ignore the sign in mean deviation from mean. So here we are taking consideration of each observations in the group, and that is why it's based on all the observations. So it is easy to grasp the meaning of the procedures. But disadvantage is we are ignoring the signs of deviations, and that is why how much negative implication is we are ignoring here. And that is why it is not widely used. So what is widely used? That is standard deviation. And what is it? It is the square root of average of square deviation of the observation from the arithmetic mean. So we have one more terminology, variance. What is it? What is variance? Variance is average of square deviations of the observation from the arithmetic mean. So we can say that variance is nothing but it is a square of the standard deviation. And that is why unit of variance is square of the unit. So we can say that standard deviation is the square root of variance. And that is why we can say that standard deviation is expressed in the same unit of the measurement as the observation. And that is why it is useful for suitable for further analysis, because it has the same unit as the unit of observation. And usually we are depict the results by arithmetic mean with the standard deviation, like the mean plus or minus 2 standard deviation of the given data. Now let us see the example how we calculate the standard deviation. We have given a data. So first we have calculated the mean, and now we have to subtract the mean from the observation, and now we have to take a square of the deviations. Remember, in mean absolute deviation, we do not have a square. We have ignoring the signs. And here we have make a square, and then we have to make a average of that square deviation, and that is nothing but our variance. And we have to take a square root of that variance so that we can get our standard deviation. The another measurement, that is a coefficient of variance. It is a statistical measure for the dispersion of data point around the means. And this is commonly used for comparing the different groups' variability. So coefficient of variation is the standard deviation expressed as a percentage of the arithmetic mean. So let us see the example. We have given a mean and standard deviation. So with the given formula, we can calculate that coefficient of variance is 20%. Here you can see that the coefficient of variance is in a percentage and not it will be having a specific unit. And that is why coefficient variance of one variable can be compared with the coefficient of variance with the other variable. For example, coefficient of variance is of weight is around 20%, but the age is 50%. So age variability is more than the weight variability. So in a summary, let us say we have to know that for given data, we have to choose the which center value or which dispersion value. So if there are no extreme values present, we can calculate mean or standard deviation. But if extreme values are present, we have to calculate the median or interquartile range. And if you have a qualitative data, we can calculate the mode, proportion, or a range. And usually in a quantitative data, commonly we are using mean and standard deviation. Thank you.
Thank you very much, sir, for your valuable contribution. Now, I would like to welcome Dr. Parag Chavda, sir, Associate Professor, Department of Community Medicine, GMERS Gotri, Baroda, to highlight importance of sampling methods, sampling size, and selection of study population. Please welcome, sir.
Thank you. I'm sharing the screen. Okay. I hope I'm audible.
Yes.
So, thank you. So today we are going in this session. We have approximately 3 topics as mentioned in the BCBR. The focus is on the study population. So in the earlier sessions, Hitesh sir took us through the study variables. So 2 important things in any research work is having clarity about on whom we are going to do the research study and what we are going to measure on them. So what we are going to measure that we have covered in the previous session. Now in this session, we are going to talk about on whom we are going to do our study. So which is having some clarity about what is our study population, including some inclusion and exclusion criteria, and how do we determine sample size. Now, as we pass through Hitesh sir's session and as we are looking at these different sessions, we understand that from this topic onwards, we are diving a little bit deeper into data and statistics and how do we deal with numbers in research. And hence, the complexity of the matter is going to increase a little bit from this session onwards. But we will try and make it simple to the extent possible. So, the first question which comes up, which needs our clarity, is why do we need a sample? So the first thing that we wish to clarify is it is neither necessary that we take up everyone which the disease of interest on the earth in our sample. So which would then probably make the entire universe. So it's neither necessary to study the entire universe to come out with findings. Studying just one sample would also suffice. Nor it is possible in terms of the resources required. So the resources that we have available with us in terms of time, money, and other things are finite. So they are limited. So it would be better to study only a sample and not all the people. Now this slide gives us some conceptual clarity about some key terms with regard to a study sample. So the first concept is the population, which is a very generic term which is used beyond the research terminology as well. And the example might be, let's say, the all population of India or all population of people of Gujarat state or a particular city. Now, what is the target population? Target population is largely, say for example, is in whom we wish to generalize our research findings. So we might be, I might be an internal medicine physician or a PG student in internal medicine specialty who is interested in adult hypertensive patients. So target population is the population in which among whom my study findings would be generalizable. So that would be usually clinically and demographically defined. So adult is demographically the age group, and hypertensive patient is my clinical definition. Or I am interested in adult hypertensives. Then from target population, next concept comes, which is accessible population. So among the target population, now I am not treating all the adult hypertensive patients available in India. I am treating only those patients who come to my OPD. So only those patients, only that target population, only that subsection of the target population who is accessible to me becomes my accessible population. So I will say adult hypertensive patients attending my OPD in a particular year, say for example 2025, becomes my accessible population. That population is accessible to me. So the concept of accessible population is helpful to draw the sampling frame. So we might not, let's say, take up everyone who is a hypertensive patient and attending my OPD during 2025. So if my sample size is small, I might take only some of them and not even all of them. So we make our sampling frame from our accessible population. What is a study sample? Is the actual patients who are meeting the exclusion criteria, who do not have any exclusion criteria, and who ultimately participate in my study. So later on, in later part of this presentation, we'll also learn how to calculate sample size. So depending on the expected sample size that I wish to achieve in my research work, I would go on enrolling those many participants. So my actual sample would be a very small portion of the accessible population or my sampling frame. So study sample is the actual patients whom I am going to recruit in my study, on whom I am going to do measurements about the study variable. This slide explains a little about the inclusion and exclusion criteria. Now, many people have confusion about this. So sometimes a common confusion is that, let's say, anybody who does not meet the inclusion criteria becomes my exclusion criteria, and that is not the case. So actually, what we are saying is that uh, anybody who meets your inclusion criteria but also meets some exclusion criteria would be excluded out of the study, which means that the exclusion criteria is within the inclusion criteria. So otherwise that particular person was meeting the inclusion criteria, but since that person has this particular thing X, Y, or Z, hence we would probably not recruit that, prefer to recruit that participant in our study. So we use those concepts to understand the inclusion criteria first. So we said that to identify target population, we use demographic or clinical characteristics. So we said that adult patients is a demographic criteria and clinical is the hypertensive patients. From target population to arrive at accessible population, we say that geographic and temporal criteria. So we said that patient attending our clinic is my geographic criteria to define or restrict the accessible population to me. Temporal might be patients attending during the year 2025. So that's how we make the inclusion criteria. Now, out of them, there might be some people on which measurements might become difficult. So we'll exclude. So anyone who otherwise meets my inclusion criteria in terms of clinical demographic characteristics and who are accessible to me in terms of my geography and the time available, among them, there might be some whom I would wish to exclude. So they could be, what could be the reasons? The reasons are mentioned in the red colored box here. So subset of people who are otherwise meeting the inclusion criteria, what are the success of follow-up efforts? What is the quality of data that I obtain from them? And what is the acceptability of randomized treatment if I'm planning randomized treatment in my study? So on the next slide, we understand this taking example. So this is one study which is the attempt is designing selection criteria for a clinical trial of low dose metformin to reduce dysmenorrhea in females with polycystic ovary. So the inclusion criteria has, we are utilizing four important elements to define the inclusion criteria for this study. This is one just sample. So in our own study, we might be utilizing these elements to define the inclusion criteria for our own study. So females in the reproductive age group is the demographic characteristics. Females with polycystic ovary with dysmenorrhea is the clinical characteristics that we are interested in. So both of these together make the target population of interest for our study. Now, how do we define the accessible population? Is patients attending OPD of the hospital, a particular hospital, and patients who are coming to hospital between January 1 to 31st December of a particular specified year. Now, out of them, someone who can interfere with the loss to follow-up. So, people who have a chances of moving out of the location or who might marry very soon and hence might become not accessible to this clinic. This clinic might be far away from them. So, the chances that their follow-up is ensured is very less. So, I might say that I'll prefer not to include them in my study to have adequate follow-up data also in my study. Interfere with quality of data collected. So patients who are already on metformin therapy, so my intervention itself is metformin. Now, patient might require metformin for some other comorbidities as well. So, say for example, if the patient requires metformin for some other comorbidity as well, so I do not have control as to what dose of metformin would be given to patients. Depending on the clinical condition of the comorbidity that the patient presents with, the metformin dose might vary, and we might have to change it in the interest of the patient. But then, since the dose is changed, the patient would not be adhering to our intervention as planned in this particular research, and hence we will have problems. So we might prefer to exclude those patients. Being at high risk of possible adverse events. So, say for example, already established hypersensitivity to metformin, if it is there, we would obviously wish to exclude such patients from our study. Or patient having renal dysfunction, we might wish to exclude. So that was a little bit about conceptual clarity with regard to the inclusion and exclusion criteria. Then we look at how these concepts, such as target population, accessible population, the actual subjects, help us get a little more clarity about internal and external validity of the study. So what we say is that the intended sample or the accessible population is the population which is accessible to us. Now, whenever we are doing any study, obviously we are recruiting patients from our own hospitals. But many times the patients of our own hospitals might not be representative of the target population. So, see for example, if I am sitting in the medicine OPD of a tertiary care hospital, it's likely that the hypertensive patients at a reasonably severe end of the clinical spectrum, which means the hypertensive patients with comorbidities or hypertensive patients with complications, preferably those patients are attending my OPD. So they are not classically representative of the target population. Let's say the target population might also include people, hypertensive people, who do not have a very severe disease, who are managing nicely with just one drug, right? Or who are managing nicely with lifestyle modifications as well. Now, those patients might be going to primary health centers for their treatment. Now, the actual target population consists of all the people who with mild disease and people with severe disease as well, right? So that's a question with regard to external validity. So whatever findings that I come out with in my study, do they are they applicable to all the target population? So when we are, so that's the question. So that's a potential error that I might be making. So if the accessible population coming to my OPD is not representative of the target population, then when I'm generalizing my study findings, when I complete the research project, share my results, I should be sharing my results with caution, saying that it cannot be generalized to all the hypertensive patients. It should preferably be generalized to hypertensive patients attending similar settings. राइट. सो हाइपरटेंसिव पेशेंट्स अटेंडिंग टर्शियरी केयर हॉस्पिटल्स के ऊपर वो जनरलाइज कर सकते हैं, टोटल हाइपरटेंसिव पेशेंट्स पे नहीं कर सकते. सो दैट टॉक्स अबाउट द एक्सटर्नल वैलिडिटी. What about internal validity? Internal validity means that all the hypertensive patients who are coming to my clinic, is my sample representative of them? So say for example, if there is a seasonal variation in something, and if I pick up myself, I'm looking at in my clinic. I'll give an example. So say for example, a medicine resident is doing a thesis and the resident belongs to, let's say, A unit, and A unit has OPD and emergency on Monday. And now we understand that when that particular resident is collecting data, the kind of patients, the clinical severity that I get among the patients who are attending OPD on Monday is very different compared to the kind of clinical severity that I would expect on Friday or Saturday. So that's a substantial gap I might expect within a week of the presentation as well. The kind of people who prefer to come up first in the morning in my OPD would be a little at the severe end of the clinical spectrum compared to, let's say, the patient lot that I end up receiving in the afternoon sessions. So from my accessible population, now I have population which is accessible to me in the morning OPD, afternoon OPD also on Monday, Tuesday, Wednesday, all the days of the week. Or I might have access to people on all the months of the year. But people presenting on these different time frames, on these time scales might be different. So we need to ensure in our sample as to whatever we are taking in the sample are the representative of the kind of patients that we see or the variety of the patients that we see. So that we call it as internal validity, that whatever is included as our study sample, or as our study participant, the set of people in our study participants, are they even represent our own accessible population, or are the people in general that we are providing treatment to? When there is an error in, or there is some bias in this, we call it as the internal validity is at question, and that's a potential error. So these concepts help us reduce the amount of biases or errors in the external validity and internal validity. So those were the concepts which helps us keep our study sample more robust. The next one is choosing study participants, and we have talked about generalizability also once. So, external validity is dependent on representativeness of the population, and second question is whether the sample is large enough. So, we understand that although we do not need to sample the entire universe, we just need a X number of people, but that X number of people has to be good enough for us to have sufficient confidence in reporting our findings. So, how do we translate that in scientific terms? That's what we are going to see in the next slide. So, we understand that our study sample has to be large enough. So, we can obviously cannot, say, for example, if I wish to find out the dose of metformin or what proportion might benefit, obviously, we cannot do such a study with just studying 2 patients, right? So, how large is large enough? So, statistics would help us define that a little bit. Another important aspects that we need to keep in mind when determining sample size is that feasibility is as important a criteria apart from first one, which is external validity or scientific rigor, right? It's always a balance between feasibility and external validity, right? So whatever software that we might use for sample size calculation, we should also be taking care of feasibility in our mind. We'll take some examples and understand when does the feasibility aspect come into picture. So generalizability of study findings also, in a sense, we should demarcate between analytical and clinical trials versus descriptive studies. So in analytical and clinical trials, if, for example, if I find out whether a new intervention is better than the older one, if I go on doing that in different places, I might come out with similar results. But descriptive studies might give me different pictures, right? So it would depend on the local prevalence of the disease, local incidence of the disease, and so on. Uh, Second aspect, we have already talked about whether our study sample is representative of the even accessible population. That's time, seasonality, day of the week, and time of the day in terms of place. That if we are going to receive a large amount of patients in our OPD are urban, then probably we will be able to generalize our findings to only urban hypertensive people and not necessarily the rural hypertensive people. And similarly, the person distribution, which we have already described earlier, saying that the clinical and demographic characteristics in the inclusion criteria. Now we come down to the sampling methods. Right now, theoretically, there are a lot of methods, and your BCBR resources also talk about a lot of methods. Also, here we are not going to talk is the probability sampling methods, which include simple random and other methods, and non-probability sample methods. So how probability sampling methods are different is that in probability methods, we before we are starting the sample, we are very sure the probability of each person in our sampling frame, what is the probability that that particular person has a chance of being included in the study. So probability sampling methods that way are little more systematic, little more robust. So we are very sure about the findings. We are sure that they would result in a sample which is relatively non-biased, whereas non-probability sampling method might be little biased. So, what's the difference between convenience and purposive sample in terms of non-probability sampling? So, the only place where I can think of application of convenience sampling in a quantitative study is, say, for example, when you are doing a pilot study to find out whether your questionnaire is clearly what amount of time does it take to do data collection, or your questions are acceptable to study population. pilot study, you can go with non-probability convenience sampling. The purposive sampling we commonly use in qualitative methods of data collection or qualitative research approach. So say for example, Chinmay sir in the previous session took some examples. So say for example, if I am interested in finding out, say for example, what are the reasons that people vaccinate their children, or if I'm interested in finding out why people from tribal belt do not prefer to vaccinate their children. So I will purposively go to those people. So, for example, if the vaccination coverage is 40%, uh, I go out specifically to those 60% people who are not vaccinated their children. So that kind of a thing. Or, say, for example, if I am interested in finding out uh, who among medical students are utilizing substance abuse as a coping mechanism to stress. So I'll have to find out from among the medical students, those students who might be using substances as a coping mechanism, which would be a small proportion and a little difficult also to find out. So I'm purposefully looking at those people who are engaging in that behavior to understand that behavior better, right? So that's the use of non-probability. Now probability are multiple, and let's use some of these next slides to understand them in better. We start with simple random. So in simple random sampling, we need to have the entire sampling frame beforehand. That's rarely the case available with us in our OPD settings. So unless we have the sampling frame or the list of people from whom do we sample, we would not be able to do simple random. So simple random, how do we do it is we give the sequence serial number to a computer and ask the computer that draw whatever number that we want. So say for example, if we have a list of 100 patients and we wish to identify only 10 people in our sample, we give the computer give me 10 random numbers from this list of 100, right? So in our OPD, we don't know who a particular patient would walk up in our clinic. So what we have is approximate numbers, maybe some rough idea, but not the exact numbers. The next is systematic random. So if systematic random also theoretically difficult in OPD setting, but conceptually, if we can explain this way that if I am expecting that today I'm expecting 50 people in my OPD, and if I wish to let's say collect sample from only 5 people, and since I wish to having representativeness from the time in terms of time as well. So I do not wish to pick up the first 5 people reporting my OPD in my sample. I wish to distribute them in time. So I might say that since roughly 50 patients are going to come, and I just need data from 5 patients, so which means that every 10th patient coming to my OPD, I'll take them up. Now, the how does the random word come here is that I ask the computer to give me a random number between 1 and 10. Suppose the computer gives me the number 6. So my first patient to be recruited in the study would be patient number 6. And then I'll keep on adding 10. So patient number, serial number 6, serial number 16, serial number 26, serial number 36, all of them would end up becoming in my study sample. And through this, if this is not completely simple random, this is a little more systematic. I ensure that from the entire spectrum, I pick up people and not preferably from one end or from a particular part of the spectrum. The next one is stratified sampling. Now, when we do stratified sampling, is many a times we usually do a descriptive study objectives, but sometimes our study objectives in the earlier sessions we talked about the research questions, and we would have come across the terms descriptive research questions and analytical research questions. So sometimes in our PG thesis, our second objective or third objective would be to compare, let's say, the finding of interest or the variable of interest among two different groups. So I might say that I'm interested in finding out, let's say, if the variable of interest is different among males and females, if the variable of interest is different among people with high clinically severe disease and non-clinically severe disease, or people who are exposed to, say, for example, a certain kind of an exposure category versus the others. So when one of our study objectives is analytical, it would make sense that since to be able to have sufficient number of subjects in both the groups, we do stratified random sampling. So say for example, if our study says that we wish to find out what proportion of school students have the ability to read nutrition label available on packaged food. And if I wish to find out, if my second objective is to compare the nutrition label reading ability of schools among rural and urban areas, I should be doing stratified random sampling. Let's say collecting data from 30 rural schools and 30 urban schools as well. So that would be stratified sampling, that I am dividing my sampling units into two strata, rural and urban, and roughly taking similar numbers from both these strata. The other sampling methods are multi-stage sampling, where we do not take the entire sample from the same sampling frame, but we go deep. That's done in larger studies in multiple stages, and each stage has a separate sampling frame. So we commonly do this in community medicine. So, say for example, if I wish to find out that what proportion of Indian school teachers they have an ability of working as bystander for giving first aid, right? So I'll select a particular district first. Within the district, I'll come out with a list of all the schools. I will not go and do the study in all the schools. I'll only, if the district has 300 schools, I might say that I'll go to only 30 schools. And within the schools also, there might be a lot of teachers. So I might sample teachers also from each school, right? So at each stage, at first stage, I'll select some district. At second stage, within those districts, I'll select some schools. And in third stage, I'll select some teachers from each of those schools. So that's multi-stage sampling. Why it's important to have adequate sample size is so that we can, so when we will be presenting, when we'll be done with the data collection, and we'll be presenting the findings or our study results to the scientific world, either in terms of a podium presentation in a research conference, or we'll publish a manuscript of our findings. And when we are ready to share our findings with the world would ask us a question. Specifically in quantitative research, the world peers would be ready with questions as to how confident are you about your study results. So if I have done study among a very few study participants, I might not be very confident that if you repeat similar kind of a study in your setting, you are likely to come out with similar findings. So larger the sample size, more is the confidence that I have in my study results. So let us, that was conceptual understanding about how large the sample size can be. Now let us use statistics to understand that better. Conceptually तो समझ में आ गया, but actually करना क्या होता है? So depending on how does the sample size calculation depend on? So it depends on your research question. So if my research question is descriptive or analytical, so if the research question is descriptive, sample size calculation is a little easy. If you wish, you can also do it using a simple calculator because the formula are very simple. For analytical studies such as cross-sectional cohort, RCT, or case control, the formula are a little complex. So we utilize the help of computers and a lot of computer tools, including computer tools which are easy to operate, easy to understand, computer tools with easy interface that a non-statistician also finds it easy to understand are available now. Now, since it's the outside the scope of this small session, so I'm not going to demonstrate use of any tool for analytical studies. But descriptive studies is something simple. So maybe I can take one or two examples of the descriptive studies to understand as to how do we derive the sample size. So within the descriptive means either we are going to find out what's the prevalence of a particular condition, or we are going to go and try and find out what's the mean value of my desired study outcome variable. So either in descriptive statistics, my variable of interest that Hitesh sir mentioned earlier, either it is on qualitative scale, finding out a proportion, or it is in a quantitative scale, trying to find out the mean or median, right? So let us go into that a little bit. So when in descriptive study, my outcome variable is qualitative, expressed in proportion. This is the formula Z square PQ upon L square, where Z is the confidence level. We'll take an example on the next slide and understand this better. P and Q are complement to each other. So P is the proportion of variable of interest. So for example, if I wish to find out what proportion of medical students are under stress, I might be interested in finding out what's that proportion. And previous studies might say that 20% of medical students are under stress. Q becomes a complement of P, which means that 80% of students would not be under stress. So this is what we feed in the formula based on previous studies, our own clinical experience, or maybe if that data is not available, we do some kind of a pilot study and find out roughly what's the expectation that we have. L is the allowable error. So when we'll be reporting our findings, so if up to what extent the errors we allow. So within what range? So if I say that 20% of the medical students are expected to be having stress, and if my study reports it to be 19%, what is the range of error that I wish to keep in my study? How precise do I want my results? So I might say that I want my study results to be very precise. So I want it in the range of plus or minus 2 percentage point on either side of the what my study results say. So if my study results say 19%, I want to be very confident, and I would say that in reality the results would be anywhere between 17 to 21. So the sample size whatever might come up, but then I might say that the sample size is very large, so I expand my allowable error and say that I do not wish to be very precise in terms of 2 percentage point on either side of the estimated proportion. I would be fine, I would be okay if I take it 5% on either side. So I say that if my study results report 90% prevalence, the actual prevalence would be anywhere between 14% to 24%. If I'm fine with that, the required sample size would be a little bit less, and I might find it feasible to do that study. So what is the actual sample size that you will take in your study is completely in your hands. So what amount of error that you are allowing is in your hands, right? So usually it is dependent on how feasible it is for us, how many patients it is feasible for us to recruit, right? So that would give us the range of confidence. Let us take this with one example. uh, the example says that hookworm prevalence from published literature is reported to be 30%. And in our area, we wish to find out what would be the hookworm prevalence. To detect hookworm prevalence in a community, so we are going to go to children under 5 in a particular community, and we are going to go and collect stool samples. And so how many stool samples should we collect to be able to detect a prevalence which might be somewhere around 30%? Now, the expected precision that we are keeping to begin with is, let's say, a small 3% on either side of the expected prevalence with 95% confidence. So these are the associated values with those numbers. P is 30%, Q is 70%, allowable error is 3%, and Z is 95%. The Z level corresponding to 95% confidence is 1.96. Feeding that into the formula, 1.96 square multiplied by 3070 divided by a square of the allowable error. So the amount comes out to be 896. Now we might say that going to the community and collecting stool samples from these many children might be a little difficult. So what can we do? This is not feasible. So we want something which is a little more manageable number. So this is not feasible. We want the number to be a little bit less. So I mean, a common mistakes that many people do is that they change the prevalence data. Now we should not be doing this, because expected prevalence is what you are expecting in your own setting. So if you change the prevalence, when you publish the paper, in your methodology, when you are justifying sample size, you would have written something. But just to bring the sample size into manageable number, you change the prevalence, and finally what prevalence you would be reporting in a result section on immediate next page in the result section of your published manuscript would be very different compared to what you estimated in the methodology section. You should not be changing the prevalence, but changing or modifying the allowable error is allowed, right? So let's do that. So instead of keeping the allowable error at 3, the sample size required was somewhere around 896, which is 900. If I change the allowable error from 3 to 5, the required sample size come down a little less, which is now roughly around, let's say, 300 only. If I say that even 300 is difficult for me to achieve, I want it little less than that. So I'll increase the allowable error to 7 on either side of the P, and I'll bring it to roughly 165. So this is how changing the allowable error would change your required sample size as well. So what this really means is that if my sample reported the prevalence to be 29% with if I had studied 900 subjects, I would report that if my study finds out 29% prevalence, the actual prevalence would be anywhere between 26% to 32% with 900 sample size. But with 323 sample size, now if my study reports a prevalence of 29%, my range of confidence within which I would say the actual true value would be is little wider. So now I would say if I could study only 300 subjects, now the actual value would be anywhere uh, between minus and plus 5%, which is between 24% to, say, for example, 34%. If I could study only 165 children, then that the range would even be a little wider. And then I would say the range would be anywhere between 22% to, say, for example, 36%. So lesser my sample size, wider is the confidence limit that I report in my study, right? Then I'll not be able to be a little more precise. So a larger sample size would enable me to be more precise about my study findings. Smaller sample size would probably not allow me to be precise, and my confidence interval would be a little wider. So that's the basic thing that to understand with regard to sample size calculation. The key message being that what would be the sample size that you will finally go with in your study is probably what would be feasible to you, and what is so how do you derive the sample size is depending on what is feasible to you, you keep on changing the allowable error. This is a diagrammatic representing sharing that it is since allowable error is in denominator is in square, it is not a linear line, right? So as you change somewhere at, let's say, 2% allowable error, the required sample size was 2000. So if you want to be that precise, 2% on either side of P, you really need to go with a very large sample size. But if you relax it to 3, your sample size comes down to 900. If you are ready to relax it to, let's say, 3.5, it goes on to 504 or roughly around 4. But if you keep it at 5, your sample size comes down to 323. If you relax it to 10% on either side, it comes down to almost 81 patients as well. Right? So it's not linear. On the earlier parts, it comes down heavily. And then beyond the 10, there is not much of a difference. With regard to the descriptive, so the formula are similar. Z square and L square remain the same. Instead of P and Q, what we report here is standard deviation. So allowable error here is relative to the standard deviation of the variable of interest. So let's take this example. If we wish to calculate sample size for a researcher who is interested in finding the mean systolic blood pressure of college students, with a standard deviation of 15 milligram, with 2 points on either side of the estimated mean. So which means that with 2 milligram 2 mmHg precision, estimated mean is 120 and required confidence is 95%. So Z is 1.96, standard deviation is 15, and relative to 15, the allowable errors, if the standard deviation is 15 millimeters of mercury, we are saying that we want it in 2 points, which means we want it, the precision has to be 2 millimeters of mercury, as opposed to the standard deviation, which is 15. So this is relatively a very high precision, very strong precision. So this would require a relatively larger sample size, which is 216. Now, if you feel that it would not be feasible for you to do this study, you can go on changing two things. One is change the allowable error, make it a little relaxed, or you improve the variation within your file. Standard deviation, as Hitesh sir explained in the earlier session, the standard deviation, in a sense, is a deviation or variation within my sample. So what else can I do to reduce the standard deviation, right? So, say for example, one of the things that we can do is we ensure that within that research, only one person takes up all the blood pressure readings. So that would reduce the amount of variability when we have multiple people taking up the blood pressure readings. So let's say if multiple people are taking blood pressure readings, standard deviation might be 15 millimeters of mercury. But if I reduce the number of people, to only 1, I might be able to bring it down the deviation to, or with the variation, be able to bring down the variation to, let's say, 14, 13, or 12. But I should be doing this in a pilot study and finding out that increasing the systematicness or robustness within my measurements, how much deviation am I able to reduce, right? So these are the examples that we carry forward the calculation from the previous slide. With 15 standard deviation and 2 allowable error, the sample size is 216. If we increase the allowable error to 4, the requirement is 54. But let's say if we keep the allowable error only to 2, but we are able to improve our measurements and reduce the variation in standard deviation of blood pressure measurement comes down to 10, then the requirement sample size is not 216, but it comes down to 96. So either we increase the precision of our measurements or we increase the allowable error. And that's how we'll be able to come down to a titration between what the software might say and what we find feasible. So these were some of the things that I wanted to highlight in sample size calculations, reiterating that descriptive, these are the formulas which were simple to use, and in descriptive studies, simple formulas. Even in descriptive and analytical, both of them, the softwares would be able to give you. So let's say if you do not wish to go into the formula calculation and just feed those numbers to the software would be able to give you the required sample size in descriptive studies as well as the analytical studies, both of them, right? But descriptive, you can use, you can use by your own hands as well, but analytical, you will need use of softwares. Now, these are some of the concepts that we can have potential clarity on. Some of the MCQs might be on this. So, say for example, in the previous slides, we took this 1.96 and which came from 95% confidence. So what is this 95% confidence? Now that is explained in this particular slide. So in this slide on the lower left corner, so there are 4 cells. So we go to the left side of the 2 cells, and if you look at the lower left cell, that is the 95% confidence. What is against that? What is available? A complement to that is type 1 error, which is called as alpha. So alpha is an error. So let us understand what is alpha error. Alpha error says that my study has found out a significant difference, but in real life there is no significant difference. So say for example, think of a medical representative. You are a clinician and a medical representative comes to your office. And say for example, medical representative comes up with a new drug. In reality, we are assuming that there is no difference in the traditional treatment that we are offering to our patient and this new drug that the medical representative is coming up with. But the study that the medical representative is quoting to promote us to utilize that new drug has shown some significant difference. So in real life, although the new drug is not different compared to the traditional treatment, the study quoted shows some difference. So in this case, we would say that type 1 error is committed or alpha is the error. Now, traditionally, the scientists in general, the medical fraternity would be fine or would be okay, or the convention says that it is okay to keep that error at 5% level, and hence we say that the confidence level is 95%. The counterpart to that is that when let's say when the study in real life, there is no difference between 2 treatment groups, and what's the chances that your study would not find any significant difference. So we want to keep that probability at 95%. So the probability of finding a significant difference, which is alpha error, is 5%. So we do not wish to keep alpha error more than 5%, and hence we keep the confidence level at 95%. That's what we feed in most of those studies. Let's think of another scenario where in reality there is a difference, which means that there are two different treatment groups, and one treatment is better than the other. Now, this, and we wish to, obviously, we wish to try and find out that particular difference. So, say for example, imagine you are interested in comparing 2 different cancer treatments. Now, whatever small the difference might be in the survival rates, we would obviously be wanting to detect that difference. So, in such scenarios, it is very important to find out that in reality, if there is a difference, my study should also be able to find out that difference. So my study should also say that we found a significant difference. So we are on the right side of the table in right upper quadrant. So when in reality the difference is there, I would want my study to be able to find out that. So that's what conceptually in statistical terms we call it as power. So say for example, traditionally we keep the power at 80%, which means that type 2 error beta is complement to power. So we are keeping the chances of type 2 error at 20%, and we keep the power at 80%. So assume if it is very important or very critical clinically to be able to detect even small differences, so we'll go with higher power. So say for example, if I'm interested in cancer treatments, I might say that the level of power that I keep has to be very high. So then I might keep the level of power a little more as well. So say for example, I'll see keep the power at 90% or something, right? So higher the power that I keep, the sample size required would be a little higher. To be able to detect that small difference, we'll need to study with reasonable, sufficient number of patients, and hence higher power would usually require a little more sample size. So that was a little conceptual clarity about the type 1 and type 2 errors that we commonly utilize, the concepts that we utilize in sample size calculations as well. So the software that you use would ask you these two numbers. Software would ask you what is the power that you wish to keep. Do you wish to keep it 80%, 90%? And what amount of confidence level do you wish to keep it? Do you wish to keep it at 95% or 98%, 99%, and so on? So upper right quadrant and lower left quadrant is what the softwares would ask you to determine when you are calculating sample size for analytical studies, comparing, let's say, two different groups. So I guess this is largely what I wanted to cover within the limited time today with regard to how do we describe and select the study sample, people on which we wish to do the study. If there are any questions, we can take them up. Fine. If there are any questions, feel free to unmute and ask or put it in the chat box as well. So then I'll hand it over to the organizers. Thank you for patiently listening.
Thank you so much, sir, for enlightening us. Hope this session was helpful for everyone. With this, we would like to end today's session. Thank you, everyone. Thank you, sir, once again. Thank you.